thoracic outlet thing. If I do this and I say, oh yeah, that gives me the tingling. How many things have I got bent here? Why am I just going to say, oh my gosh, there's compression of the median nerve at the wrist, it must be carpal tunnel. Why wouldn't it be thoracic outlet? Or why wouldn't it be elbow? Or why wouldn't it be that, the nerve is, I think of it like, they have a little tiny bit of give, but not much. So it's kind of like if you take a string and you put it down on the table with a little slack, and then you pull all the slack out. This is pulling all the slack out. Okay? As is what we were taught as nerve gliding. If you stretch as far as you can both ways, what is gliding about that? Those are provocative tests. Those things are in the Hunters. They show this is, median nerve, and then your ulnar, you try to like hypersupinate, and no, this is ulnar here. This is, I kind of quit doing them, but that's nerve stressing. You can use those. You can use those for provocative tests. If you want to glide the nerve, you get into position, you put slack on the one end, and you do the stretch on the other end. And then you put the slack on the other end, and you stretch. The PTs now call it flossing. So think flossing. But what we were taught, there's nothing gliding about that. So, big surprise, the Tinels and the Phalens, as we know them, have poor sensitivity and specificity. So they're crappy tests. And then there's information in this vendor, which I think that's the Kasdan book. But a bunch of our Air Force colleagues, physical therapists, Rob Weiner and Julie Whitman and a bunch of others, they did a study on developing a, what do they call it study? It's in there. It's actually in the references, not the additional. Developing a protocol, a clinical prediction rule. There you go. And so they talked a little bit. Now I quit doing Phalens altogether, but before I quit, I would have the patient do one side at a time, arm on the table, and just bend the wrist. And I would only do one at a time so they could show and tell. If they do this and I say, get any numb and tingling, and they say yes, well, what if, had I actually asked them, the numbness and tingling was in the ring finger or small finger? Or what if it was their left earlobe? So show and tell on your provocative test. What's the time check? So how far in am I? I got an okay, we're doing good, I think. So this is the protocol from the Indianas, just for reference. Okay, so we're about ready for our videos next. Okay. So what I learned from Kasdan or Sanders, or Kasdan and Sanders, or one or the other, I actually learned that you can palpate for the distal nerve distributions in the forearm. And Tinels, you can Tinels all kinds of stuff. You can do Tinels, the tapping for the median nerve at the wrist, the ulnar nerve at the wrist, and the sensory branch of the radial nerve at the wrist. You can do Tinels for median and ulnar nerve in the forearm. You can do deep palpation for radial nerve in the forearm, and you can of course do the Tinels for your distal triceps. So we did a little video with my new and disimproved voice. I felt like if I brought somebody up to demonstrate with the room this big, you wouldn't be able to see it. So we did a YouTube video. So we'll see how that goes. You can reference it if you go to, I think the very last slide, it has some of my information. So if you go to YouTube, and then in the search bar, just type, and I don't know if is it case sensitive? I don't know if it's case sensitive, but it's capital RMC, and then lowercase RAYNE. So Rosemary Crane, RMCRAYNE. And if you that'll pull up my channel, and there's only like 4 or 5 things on my channel. And so this one is going to say, I forget what it says, something like distal nerve testing in the upper extremity or in the UE, something like that. Have you got handouts? Raise your hand if you need handouts.
Some of the handouts are missing pages. Some pages are, I have 10 pages.
Yeah.
I have like,
Well, it's back in front.
yeah, but I have nothing that's got, mine are just back in front of the same ones.
We'll show her.
I need another.
So we're going to roll. Keep raising your hands.
And this is our survey of distal nerve distributions. So, signs of irritability for median nerve, ulnar nerve, and radial nerve at the wrist and in the forearm. So we'll start out and just do a palpation. It's like walking your fingers down. So I'm on the ulnar side or the small finger side of the forearm. So this would be ulnar nerve distribution. That ulnar nerve lies just beneath the flexor carpionaris all the way down the forearm. And then I can palpate over the flexor mass here for median nerve symptoms. And then the dorsolateral mass here for radial nerve symptoms. So we would be looking for the client to tell us usually achy pain that would be consistent with where we're palpating that nerve distribution. If the client reports referred pain down into the hand, or if they report numbness or tingling, I would still count that as a positive test. So then when we do our Tinels, we want to start at the wrist. Sometimes you will provoke symptoms and the patient cannot return to baseline. In other words, they'll get an achy pain that does not subside, or they'll get some numbness and tingling that they can't shake off and won't subside. And at that point, ball game's over, because you would get potentially false positive for everything else that you tested after that. So always start at the wrist, and I usually thump not just right on the flexor retinaculum or the transverse carpal ligament, but usually over, above and below the wrist crease. And so with the client, I'll start out tapping really light and watch their face, and then go progressively a harder tap, because you don't want to set them off if they're super hyper irritable, and you can tell that with a light tap. There's no need to cause them unnecessary discomfort. So here, of course, in this area, you're looking for median nerve symptoms, usually these radial digits. Then you can come over here and do Tinels for the ulnar nerve. And here at the base of the thumb for the sensory branch of the radial nerve, or the dorsal sensory radial nerve. For some clients, you have to come a little bit kind of off to the volar surface here. Okay, so that's for radial nerve symptoms. Then we'll go up into the forearm. So ulnar nerve, we can do Tinels all the way down the distribution. Now, a lot of times clients will not sense anything until you get pretty close to the wrist, in which case I'm going to record that as positive provocation at the wrist, not in the forearm if I'm already more than halfway down. For the median nerve, you kind of want to rotate the hand, and you can kind of feel that drop off where you're kind of off to the side of that flexor group, and a little bit closer to getting that pronator. And you do a tap like this, and that would be for median nerve, or for pronator syndrome. Now, for radial nerve here, it's not really a Tinels. I'm going to look for the lateral epicondyle. And then you're going to come down and kind of forward about 1.5 inches or so, and just press that spot. I mean, you can kind of play up and down, but usually right about there, and they'll experience some significant discomfort or achy pain there, and that would be a positive sign for that radial nerve. Then, of course, you can go up for ulnar nerve. Sometimes you'll get a finding of tenderness to palpation. You just had a jump there. Tenderness to palpation to the medial distal triceps, and then here, of course, your cubital tunnel. You can tap. And again, that one is very close to the surface. I mean, if you hit anybody hard enough, of course, we'll get a positive response there, because we've all had the funny bone sensation. So again, I would start really light, and then maybe progressively tap a little harder. And again, you can get numbness or tingling anywhere down this ulnar distribution, or into the fingers here, achy pain or numbness, tingling. Any of those would be a positive finding.
books. Books are our friends. Okay, I don't know how you have this.
That's it.
Hang out for a second. Okay, am I live again? Okay. So hopefully that was, oh, and we're already back to our presentation. I thought I was going to have to stop. This is upside down. I'm not usually wired for sound. Okay. So, suspicion for, and here's the term I use with the doctors, or that I use in my note. Instead of thoracic outlet syndrome, and then you get a lecture about, the cervical rib, blah, 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 blah. I say compression, proximal compression of the neurovascular bundle in the upper chest. So that's why I have all these blurbs written out in my template where I can just eliminate the ones that I won't, because I don't want, because that's a lot to write out. But thoracic, postural, or sometimes I'll say postural positional thoracic outlet. Okay, so here's the no-brainer. So when I'm trying to start figuring all this out, and I'm basically asking, do you have numbness and tingling in the carpal tunnel fingers, right? And they'd say, well, no, it's not. I wouldn't quite, you know what it feels like? It feels like somebody cut off all the blood in my arm and I need to get it back down in there. So, I mean, it didn't take 200 people to tell me that. It's like, no, they're telling me this is circulatory. Okay, and indeed, so that's an important thing that patients might tell you, that they're very clearly telling you circulatory symptoms. They may also be telling you nerve systems, but symptoms, but some circulatory symptoms. I'm not even on drugs. History of activities with the arms forward or overhead. So the classic they talk about is overhead work. And I don't know good civilian examples. In our world, that's our comm squadron linemen, doing the overhead work. Everybody has experienced this kind of thoracic outlet syndrome, right? I mean, what happens when you change a light bulb? If it took an hour to change light bulbs, they would not put them in the ceiling, right? Okay? So what happens when you change, or guys, when you're doing your French braid in your hair? So what happens when you got your arms up for a long time? Your hands might go to sleep, or your arms just feel really heavy. I mean, you can hold your arms up down here. They're the same arms, right? Okay, but this compression of the nerve, and I do have a good netter slide somewhere in here that seemed logical at the time. So there's a lot of stuff in the literature about overhead work, and then it's kind of like the fine print. And you might see this with forward posturing, such as people who work at a desk all day, as though that's not very many people. That should not be fine print, right? Okay. And then another one is the report, and this one you kind of have to tease out, but not just tired, but heavy. The sensation that your arms feel heavy. This used to happen to me all the time, like fiddle-faddling in the back seat of my car. So like if I wasn't even a traveling therapist back then, no home health, but I'd have my stuff in the back seat of the car, and I'd be like, digging through the bag, hey, the arms just get feeling so heavy. And so this is something that kind of comes and goes. Well, the problem is when it comes and stays, right? But I mean, we've all experienced this from time to time. So so at our house, we say, I'm feeling a little TOS-y. There aren't really any other people in the house except for our sister to irritate, so we can talk all the nerve talk we want to. Okay, so driving, washing or styling your hair. I mean, I don't usually ask patients, about the light bulb thing, but I will frequently ask them about symptoms with driving or symptoms with washing or styling their hair, which at one point I was buying into the whole orthopedic, model of carpal tunnel syndrome, and thinking, that driving, just like hands, waking up at night with your hands numb and tingling from sleeping, that those things were pretty much pathognomonic.